Hello and welcome to today's HealthPayerIntelligence.com webcast sponsored by Appian, Next Generation Provider Relationship Management. This is Kyle Murphy, Senior Director of Editorial at Xtelligent Media and moderator of today's presentation. We will begin with a presentation by our featured speaker, followed by a brief word from our sponsor. Time permitting, we will conclude with a question and answer segment. Audience members can submit questions at any time during the webcast using the question tool to the left of their screens. For all technical matters or difficulties, click the Help icon at the top right-hand corner of the screen. A copy of the presentation slides is available under Event Resources to the left of your screens. A recording of the webcast will be made available following this presentation. Dr. Linda Ellis is Chief Medical Officer at Independent Care Health Plan in Milwaukee, Wisconsin, serving duly eligible Medicare and Medicaid beneficiaries, all of whom are at or below 100% of the federal poverty level. Dr. Ellis is responsible for utilization and disease management, population health initiatives, and oversight of medical and pharmacy services. With that, I would like to hand the floor over to Linda to begin today's presentation.
Thanks, Kyle. I appreciate that. So I'm happy to be here today and am grateful for the opportunity to share some of the insights that we here at Independent Care Health Plan have experienced. Today, some of the objectives that I hope that I'm able to touch upon are to discuss ways in which provider and payer organizations can have more open and transparent communication, reduce provider friction, keep providers in network, and incentivizing providers to ensure continuous quality improvement. And sometimes when we do have to respond to emergency regulatory and policy changes, how we can better ensure that process goes smoothly and efficiently. So, goodness. So Independent Care Health Plan began in 1994. It was a joint venture between the Wisconsin Health Organization and the Milwaukee Center for Independence, which is a unique beginning because the Wisconsin Health Organization was later assumed by Humana, a for-profit organization, and the Milwaukee Center for Independence is a not-for-profit organization that specializes in long-term care services for the disabled. So we have a unique parentage. We do have multiple plans. We are exclusively a Medicare and Medicaid managed care organization, though, contracting only with the federal and the state governments. In the state of Wisconsin, we did not expand Medicaid with the ACA, and so as a result, all of our members who are Medicaid eligible and those who are dually eligible are at or below 100% of the federal poverty level. So it's a challenging and sometimes daunting task to be able to negotiate some of the challenges with providers, as well as making sure that our members who are very vulnerable receive appropriate and timely services. We have 3 dual eligible special needs plans, a fully integrated special needs plan. We serve Badger Care Plus, childless adults, moms, and kids, so those individuals who qualify for Medicaid who are in need, but who go in and out of eligibility based on income. And then our SSI Title 19 disabled individuals. The exciting thing about iCare is that we this year are a 4.5 star rated plan for our DSNP and our FIDA-SNP, and that's really exciting for us because we're the only plan that I know of in the country who has a 4.5 who has 100% of the population at or below the federal poverty level. So that's an exciting thing for us, and we're very proud of it. So here at Independent Care Health Plan, we do not have providers who have offices that see our members. We are a care management model, managed care organization, so we're very member-centric, but yet at the same time, we have to focus on population health issues as well. To do that, we do identify and risk stratify individuals within defined populations in a number of different ways, which I hope to touch upon. And we develop care management strategies to align the member, provider, and our organization goals. the thing that I think we've learned and has been really a major, not a revelation, but actually a really nice validation of, practicing medicine, in that in medicine, it doesn't take an individual practitioner. It really takes the whole team to help and support each patient. And the same thing is true here at iCare. So provider engagement for us takes an organization. It's not just one department who's involved. It's all of our departments who are involved. So when we go out and we do a value-based payment update for providers, it's not just our network development team who is responsible for reaching out to those providers for these discussions. We often have many of our teams and our departments within that meeting. So it wouldn't be unusual for network development to bring their director, have care management staff there to discuss their model of care, prior authorization representatives, analytics there, because we can't do anything without our analytics. It's where we get our data and to help support these discussions. Understanding the quality metrics and where each of our providers sit is very important. We provide all of our providers with report cards, and I hope to show you one of those a little bit later too. Marketing is sometimes involved. Operations for all of our claims questions that our providers may have of us. It wouldn't be unusual for our CEO to go to these or some of these meetings. Vice President of Accountable Care, who oversees care management, certainly would go. And I would also go as well, especially if there was representation from any physician or clinical teams there. So in truth, the reason that it's really successful is because we take the time and we have a staff that's willing to travel to providers' offices and locations. And, as we all know, one of the greatest assets we have as an organization is our team members, our staff. And to actually take the time away from what they're doing, because this is a very important part of their job as well. Our job, all of our jobs, is to meet with our providers. We take it very seriously, and we value the relationships that we build. Aside from the direct outreach that we do, which I'll be talking about further, we do have print materials, and of course we have an internet site. We do have regular provider bulletins that go out. We have quarterly updates as well as monthly updates, especially if there's something urgent that needs to be communicated to our providers as well. Of course, if it's urgent and needs to be communicated to our providers, we don't just limit it to putting it on our internet site or an email flash or a print material sent out. We also will pick up the phone and will provide outreach to especially the providers that any urgent change impacts. We do have provider training sessions. In fact, we just had one yesterday for our home health agencies that provide personal care worker services. We do this annually. The staff sometimes has a turnaround there, and for our contracted providers, we just like to ensure that any updates that we have to our process are communicated, not only in a timely fashion, but also updated annually. So we have an annual competence that we sit down and we discuss. And we also outreach to providers of subacute care and long-term care social services as part of a regular quality initiative that we have. So when I was thinking about how we really reach out to providers and in what instances do we do that, it's not just in our value-based payment contracting sphere, although we do that. We also have a lot of other reasons to reach out to providers, and that is another reason why it really does take the whole organization. We have interdepartmental objectives where we reach out to providers in order to ensure that we have appropriate communication so that we can care manage. We also have interorganizational policies or procedures involving credentialing or when we have updates to our prior authorization process, that it's imperative that we reach out and make sure that we maintain that relationship with our providers. And then we also have provider-facing organization initiatives, and these are some of the more exciting things that we put together at iCare that directly affect not only individuals but our populations. And ensuring that we have buy-in and we have enthusiasm and partnership with our providers is so crucial for these services to really roll out. So I wanted to talk a little bit about some of the relationship management that we do. We have in our intradepartmental objectives, we do have our FIDA SNP. Our FIDA SNP is our fully integrated dual eligible special needs plan. For all of those members, they have both Medicare and Medicaid with us for acute and primary services. And then the integrated part comes through a waiver through the state of Wisconsin to provide long-term care social services. While we do have a relationship with the state DHS, and they do review all of the facilities in the state that serve waiver members, it is very clear, and it has been made very clear to us, that part of our responsibility is to ensure the quality in all of these providers. And in the waiver program, all of our providers that service our partnership members or our FIDA SNP members have to be contracted. So as part of that contract maintenance, we do follow up on a regular basis with the quality of the organization. That has a lot to do with their policies and procedures, and we help them with that. And then we also, for especially our long-term care placement settings, our residential facilities, we do have outreach to our providers, and we let them know that we're going to be asking the members about how they feel about the facility. We have a questionnaire that we provide them, things that are important to our members, like do they like the facility? Do they feel safe at the facility? Are they engaged in activities that they like? Are there any activities they would like to do? And we let the providers know that we're doing that. We engage our members as well. And then we also outreach afterwards, and we let the provider facilities know what our members felt. So that kind of outreach sometimes could engender maybe some concern on parts of the providers, but we really have a great team that goes out there personally and has this personal relationship with them. And so if there are ever some changes that we might request to make on behalf of our members, we tend to get a really good response, and we've got some great providers. Just as an aside, one of our provider facilities had the suggestion that one of our members wanted to sing. So they ended up taking 6 of the residents who were all at that facility to an event, and they had our member sing in front of everybody, which was something that absolutely made his day. But that kind of engagement and willingness to help and support some of our members frankly couldn't be possible without those relationships. We also have as part of the waiver service, part of our DHS service for our moms and babies, we have a prenatal care program. And our OB providers, if they meet all the requirements of the OB care plan, do get a supplemental payment that's paid by the state. iCare has nothing to do with that. But we do facilitate those OB providers to make sure that they get reimbursed for all the work that they do for our members. But that does require a lot of clinical documentation and engaging the member. We like to partner with our OB homes to ensure that if there is a prenatal care appointment scheduled, that we make sure that we arrange transportation if the member needs it. We'll even go, if the member would like us to go, one of our care coordinators go with them to the appointment. Anything we can do to partner with the provider so that they decrease the amount of no-shows, and they also are able to provide the care that we know they want to provide, and we know that we want our moms to receive. It also helps building that relationship because as OB homes, we like to also have our newly pregnant moms be seen and have an OB provider. And so this kind of engenders that ability for our members to have access. Further, we do have quality concerns every once in a while that do pop up. Sometimes they come directly from the state. Other times they come from internal organizational discussions. Clinical documentation and other requests for information are sometimes very difficult to come by. We do have a struggle sometimes with providers who don't feel that we meet the HIPAA requirements to give us information without the patient's consent. And that oftentimes takes a personal phone call or even just going there in person and introducing ourselves and, discussing federal and state law, and also seeing what we can do to make that transfer of information less painful for them. If there's some way that we can have electronic transfer of clinical information so that there's less administrative burden for them, we'd like to do whatever we can to facilitate that. Provider notification of our quality improvement review. That's also something that we'd like to reach out and let them know that we are very actively investigating any time that there is a complaint from one of our members or a quality concern. And we are very transparent in what our process is, which is also very important in order to engage our providers and get their cooperation sometimes in sending us the clinical data that we need. We also are very efficient at communicating our resolutions after we've done a quality concern and a quality improvement investigation. A letter goes out from me, and it has a summary of our findings, and we work together to establish a resolution if we need to. And since we've really instituted that process, we do find that our communication with our facilities, including our subacute care facilities, has been a lot easier. And I know that's good for our members, and it's also good for our relationship with our providers. We do have inter-organizational procedures and policies, such as provider credentialing. Provider credentialing is very interesting because we do find when we're contracting with large groups of providers that the credentialing process is a bit daunting. We certainly like to follow NCQA standards in terms of our credentialing process. And for any large provider, if they can demonstrate that they do have all the processes in their organization in place that support the NCQA requirements, we're happy to do delegated credentialing, and that seems to make a big difference, both for their workflow as well as ours. We do have a provider credentialing committee. I chair that committee, but I share that with 3 or 4 other community physicians. So we review all of the new and renewed credentialed providers, even if they don't have it's just an easy credentialing process because nothing's changed in their application and they're still in good standing with the state and federal government. But then for individuals where there are some concerns, maybe a gap in work or something like that, the team really discusses it, and a letter goes out collectively to any type of provider should we have to have further questions or perhaps maybe consider not including them in our network, which has happened in the past. But I'm happy to say that not very often. So I think we've got a really good process in place, but it's also one that's very transparent, that we're in frequent communication with our providers and their organizations. Prior authorization updates, I think, are probably the most controversial things that we've gone through here at iCare. And the one thing that we do is prior authorize, because we don't generally have that clawback at the end, reviewing all the claims that come in to make sure that there's medical necessity met. So sometimes when we add something new, like urine drug testing, for example, that we prior authorize, we understand that that is going to be a lift for a lot of our providers, and we certainly want to reach out to them, explain why we're doing what we're doing, and also support it from the perspective of the state and the federal governments. And I know that was very challenging at first, and it's become less or so in the past 9 or 10 months, but I know it is still a challenge. And so the other thing is that communication and reaching out to providers doesn't end with that first time. It really is something that we nurture and we massage, if you will, because we know that just because we've reached out once doesn't necessarily mean that we don't need to continue supporting that relationship. We do have a provider portal. Our provider portal right now is only for claims, so our providers can get a unique PIN number and log in and see the status of their claims. Sometimes that shows a prior authorization that's linked to the claims, but we don't at this time have a provider portal for prior authorizations. That's something that we are planning on introducing in this coming fiscal year. I think that'll go a long way in supporting provider relationships with prior authorizations. Also, our provider newsletters to go out, and we have value-based purchasing visits, which are extremely important. And in those value-based purchasing visits, we do have our prior authorization team there, or at least a representative of that team, to answer any questions and have at the ready any policies or procedures that if the provider staff wants to go over, we're more than happy to do that and really listen to what their concerns are. We just recently had a value-based purchasing meeting with one of our home health agencies, and the home health agency came up with an idea that actually we agree with, and so we're going to go ahead and change our process because it just makes it easier for them, and it certainly isn't antithetical to any of our regulations by the state or federal government. So that's another good reason to, really engage our providers and to listen to what they have to say. If we're a good partner to them, I think that also goes a long way in some of the heavy lift that our providers have to do in terms of documentation for us. We do get claims questions every once in a while, and it's very nice to have our claims specialists around, and we do have provider specialists in our claims department that are assigned to each of our provider organizations. So they have somebody who's there that we can do a warm transfer to if they have any claims questions, and somebody who will hold their hand and help them through any questions that they have. And if they have challenges on any claims denying because of modifier codes or something like that, they can walk them through that. And so that's gone a long way, I think, in supporting our provider community. We do have some value-based payment contracts, which is really exciting. We do have 2 physician groups, actually one physician group and then one major healthcare system, which is a really big physician group, that we do value-based payment contracting with up and downside risk. And that up and downside risk is based on MLR performance as well as HEDIS measures. So we do provide those report cards to all of our providers, especially if we're engaged in a value-based payment contract, or if we are just, working with them, even if they're not risk-sharing with us, we do give them a report card of what we're looking for and where they stand compared to their peers, which is a very interesting thing. I thought at first that maybe they wouldn't really care where they stand with their peers, especially our skilled nursing facilities. And it turns out they do. So when we say that you're number 7 out of 10, that makes a difference for them. We also notice that's true for our FQHCs. So when we've identified where they stand in terms of the HEDIS measures and any pay-for-performance measures, and they notice that they are lower in the pack, they tend to actually make a difference and change some of their processes and really meet some of those measures. We do have co-branded plan partners, and on our co-branded plans, again, that's our our large healthcare system that we have a D-SNP plan. And we've just partnered with one of our family care, which is another type of a waiver service that doesn't integrate acute and primary services. And we have joined them with a Medicare plan, and they would provide the Medicaid. And so we're partnering, and we are providing all of that data analytics for all of the members in this new plan, and providing report cards to them. We are treating them as, of course, colleagues. We are partners, but then we also share our information with them about HEDIS measures. And so in terms of communication and outreach and building that relationship, that's especially important for these contractual relationships that we have for managed care contracts. So the image that's on the screen right now is actually an overview that we provided to one of our independent physician networks with whom we contract. They are engaged in upside risk, and so this is an overview of our HEDIS and P4P measures, but specifically for them, all of their physicians in their network and all of their non-physician providers who are responsible for HEDIS measures and P4P measures. And the ones that they're responsible for in their contract are highlighted yellow. So the data that we do give them in addition to this is also further stratified by their individual provider as well as the patients that they see who are our members. And we kind of support exactly, we give them exactly the data that they need to know that Mrs. Smith is eligible or needs to have her mammogram, and you know, who the provider is, so that we can shepherd their organization, administration, and leadership to help facilitate movement for all of their providers in their organization. The provider-facing organization initiatives, I think, are especially exciting. We have a chronic disease management program, and in the chronic disease management program, we've identified 5 disease states through our data analytics that are responsible for the majority of our inpatient admissions. As a part of that, we do have telemonitoring program that we have a value-based payment contract with Medtronic. And I'm especially excited about that because we have up and downside risk with Medtronic for all 5 of these measures. And they provide a service where they provide the hardware for the telemonitoring as well as the software, and they have a cadre of nurses that review all the data. The interesting thing about that is that their portal, they have a provider portal that we, of course, access, but they can give access to each member who's enrolled in the telemonitoring service. Their primary care physician can have unfettered access to this portal as well. So reaching out to our members' primary care physicians or the physicians that they have treating their chronic diseases and engaging them to see if they're interested in using this portal would be great. There's no obligation for these providers to do that. They don't get alerts going to them unless they sign up for it. And some of our primary care providers have signed up for urgent alerts on their patients, which is a great thing to see. But again, reaching out and communicating that this is a program that we're doing to help the health and well-being of our members, and cooperate with our providers and kind of work as a team to make sure that our members are taken care of the best way that they possibly can. We also use telehealth, and we do have a contract with American Well, and they provide the telehealth providers. That was a little heavier of a lift, and I've been doing that for over a year now. Initially, we had a lot of pushback from providers, naturally so, because it's change and the concerns about telehealth and the quality of services that would be provided to their patients. But now we have, with more outreach and continued visits, and again, the visits are not just with me. They're with our Vice President of Accountable Care, our CEO, our Network Development Director. So really, it's the full backing of the organization supporting these efforts, And I think that means a lot to our providers to know that we're taking the time to say as an organization and as the senior officers and the senior leadership in the organization are really supporting this. And it's actually, starting to take hold, which is a great thing. We do also have a pharmacy outreach program that I want to make sure to really highlight, because adherence is a big deal for our members, whether it is because of a social barrier, a financial barrier, or a health literacy issue. We partner with a pharmacy called Hyatt Pharmacies here in Milwaukee, and in the Milwaukee and surrounding counties, this pharmacy has made it their goal, their whole objective, to serve people who are vulnerable. Our vulnerable populations are Medicare and our Medicaid duals, and they do a great job. They'll go to patients' homes, they'll give them flu shots, they will try to enroll them into a 90-day fill, bubble packs if they need to. They teach wellness, so they're trained and certified wellness coaches for diabetes, and so they also assist us in our wellness classes for that. So this relationship has really grown, largely because of our pharmacy director really outreaching to Hyatt and Hyatt really embracing that relationship. And because of that, now they also are working with us with our CMRs, and we have monthly health clinics that we have members come and they can get their retinas scanned for their diabetes, and they can get flu shots, they have their CMRs, and Hyatt actually sends staff just to our health clinics so that they can support our members, whether it's a pharmacy need for adherence or it's their CMRs or flu shots. So they're a great partner with us. And again, that relationship is so important to us that we do engage with them on a regular basis. We do have two other programs, Follow to Home Readmission Prevention, and for that we partner with home health agencies. So reaching out to our home health agencies and asking them if they would be willing to have an addendum to their contract to follow some of our members that we risk stratify, that we think are at a high risk for readmitting within 30 days, and then really taking the lead on a program if they need to go and do an inpatient or in-person visit into the patient's house, or a telephonic, status check on a regular basis. But we do have a bonus payment attached to that if they can follow the member for 90 days without them having to readmit. And so, working with our home health agencies, and it took a lot of time. Our Vice President of Accountable Care spent a lot of time, especially with our network development team, really trying to work on a contract that would be amenable to all parties. And at the end of the day, we actually have results with this program, and it's our members who are coming out ahead, which is wonderful. We also are trying to prevent overutilization of our EDs. We've had members that go in 35 times in a month. And so we're partnering with our EDs where they visit the most, and our care management staff are meeting with them, with their ED staff on a monthly basis. And that has really made a big difference in our members who are going to our EDs. We have a member who likes to go to one of our EDs on a regular basis every day because she likes the lemonade and the peanut butter sandwiches. So we have one of the staff in the ED who sees her coming, pours her a glass of lemonade and a peanut butter sandwich, and she sits down and eats. But she doesn't register because she was only there for the food. So, learning about our members and really integrating with our providers has just been a fantastic experience for us. And we're starting our behavioral and mental health and AOTA services integration plan for 2018, and we're planning on continuing that as well, especially with our community behavioral health providers. So, the take-home points for me, communication is the key. CMS, in terms of our outreach requirements, our best practices say, guides us that communication comes in many forms and in many ways and frequently, and I couldn't agree more with that. There's no one organization or one department within our organization who's responsible for provider engagement. All of us are, and the more we do it, the better we are. And then our value-based incentives are key to engaging our providers. If we come up with a common goal, sometimes that's enough, that we are helping our patients and their health. Sometimes it's aligning with HEDIS measures and MACRA. What sort of quality measures are our providers engaging in, and how can we align that and have a value-based contract with that? And then sharing that data with them is very important too, especially how they rank with all of our other providers that we have. Because how you're perceived and how you perceive yourself are really important to our providers that we've noticed, and we appreciate that they don't just want to do a good job, they want to do a better job. And with that, I'd like to turn it back over to Kyle, and thank you all very much for attending today.
Thank you, Linda. All right. Now I'm going to go ahead and introduce Cate McConnell, Global Healthcare Payer Industry Practice Lead at Appian.
Thank you so much, Kyle, and thank you, Dr. Ellis, for that really amazing, detailed, and insightful look into next-generation provider management. My name is Cate McConnell. I'm the Global Industry Practice Leader for Healthcare Payer at Appian Corporation, and we're just going to spend a few minutes at the end of this webinar describing what Appian does and why we chose to sponsor this webinar today. We're really gratified to have Dr. Ellis and her knowledge to join us today. In terms of Appian, you've probably never heard of us, and we're going to change that. We are a company that was founded in 1999 and headquartered in Reston, Virginia, but we are a publicly traded company now as of this year, 2017, and we are a software company. Let me tell you a little bit about what Appian does. Appian provides a leading low-code software development platform that enables many organizations, including those in healthcare, to rapidly develop powerful and unique applications. The applications that our customers create on Appian's platform help them drive digital transformation and competitive differentiation. We'd love you to learn more about us by visiting our website. We are the only platform rated by Gartner and Forrester, who are leading analysts in the software field, as a leader in both low-code application development and business process management for deploying powerful, modern applications on-premises or in the cloud. So that's a little bit about us. The reason why we are so interested in working with the healthcare industry are because of some of the things that Dr. Ellis talked about today. You heard Dr. Ellis talk about the clinical and the organizational dimensions of how leading organizations are really engaging in provider relationship management. They're creating and innovating new ways of engaging with their providers. She described a lot of innovative programs, and those programs were really tailored to not only the patients and the member population that they seek to serve, but also tailored around the needs of their providers. The providers are now customers for many of our healthcare plan organizations that we work with. Appian seeks to help these organizations to focus on those patients and providers and the programs that they want to deliver, not worrying about their software interfaces or their workflow processes. Appian does really three things, and we do it across industries. So we help companies do three things that they need to do. Number one is many companies have lots and lots of legacy applications. But in this new world where everything is digitally enabled and we have to innovate very quickly, a lot of times there's a need to fill the white space between those applications where we need two applications to speak to each other, or we need to tie three applications together in an organization to create something new. Appian can help you do that. Appian can also help you create new applications on the fly because, let's face it, many of us in our organizations have software that might have been bought 5 years ago, 10 years ago, maybe even 30 years ago. And the needs that we have now and the demands we're putting on our IT applications weren't anticipated when some of our applications were purchased. So we can help you do that. You can see we're trusted across industries. Government, financial services, government, financial services, and healthcare and life sciences are just 3 of the industries that we're focusing on. And we started out actually in the government segment and have invested time in achieving many of the certifications that are important in this industry, in these industries, as well as the HIPAA certification. So I want to talk just briefly about some of the provider management use cases that Appian might help. And some of these categories might be very familiar from Dr. Ellis's talk. So while Dr. Ellis talked about the needs of the organization and how the organization needs to work together to truly enable next generation provider management, what we want to help is enable organizations that are far thinking with the tools to do those things. So while we have people who are willing and able to do it, and you have great strategies and organizational designs to achieve it, you also need your software systems to support that. So some of the things we can help with in these areas around provider and network management are, your network design. Those analytical tools exist in your organization, but we can use Appian to tie those things together and create transparency layers so that everyone can see and share what's being built. Some of the other things we can help with is your provider recruitment and enrollment. Most of our customers are mobile enabling those activities now, from the enrollment activities to the site inspections to credentials management. Those things need to be done across groups, across lines of business, across geographies, sometimes across multiple organizations or business units within a health plan. And we can help enable that. Not to walk through every single thing, I'll just call out one other. Provider data management is critical in organizations, and I've seen personally many times provider data can reside in multiple systems. It can be stored in different ways. And when you have to publish out your provider directories and tell your customers who your providers are, that can often be a very difficult problem. Appian has worked with payers to solve this problem and be able to seamlessly provide your provider data in the ways it needs to be consumed by different applications, whether it's your directories, your provider portals, or even if you are supplying provider names to see some of the consumer rating websites that are becoming important now in consumer choice. And then within medical utilization and population health management, again, we mentioned that Appian can help tie together multiple applications, build new applications on the fly, or fill white space between applications. So these are some of the use cases within care management that we've helped enable. Prior authorization, Dr. Ellis talked about that, how critically important it is and how sometimes difficult it can be because the systems within health plans that enable these processes aren't necessarily aligned, tied together, and made to perform to today's standards. That's something that Appian has experience working with. So again, we are looking to work with health plans that are looking to take their capabilities to the next generation, digitally enable them, and digitally transform them for not only today's healthcare consumer, but to serve the needs of providers as we engage them in this new healthcare world that we find ourselves. So I want to thank you very much, invite you to contact me or any of us at Appian Corporation if we can help you. And I want to thank Dr. Ellis for appearing today, and I want to turn this back over to Kyle. Thank you.
Thank you, Cate. All right, we're now going to move on to the question and answer portion of the webcast. A reminder to audience members that they can submit questions at any time using the question tool to the left of their screens. So without further ado, let's move on to the first question. So Linda, how do you foresee provider relationship managing management changing as value-based care and risk-sharing agreements become more commonplace?
Oh, I like to think it's going to get a lot easier because I think once everybody's engaged and everybody has skin in the game, that we can align. First, hopefully there will be more alignment between providers and payers, between Medicare and Medicaid, so that'll be easier to do. And I think as we get more of these value-based and risk-sharing contracts in place, it'll put more pressure in order to ensure that that happens. But I think ultimately it's to everybody's gain and nobody's loss to work collaboratively together. So as this becomes more commonplace, I think it's going to be easier and more fluid.
All right, next question. So what pathway does iCare follow when a provider perhaps does not meet the documentation standard after receiving timely feedback?
Well, I presume this is related to providers that might have a quality concern or that nature. There's, when we don't get clinical documentation, outside of that when we need it, if we're following members in a subacute care facility, for example, it is challenging sometimes, but generally we haven't had to go through any type of, getting legal counsel involved or the most thing, the biggest struggle I think that we have is just calling the administrator of the provider organization and, just having a conversation. And generally that's what it takes. It's a little more challenging when we have big healthcare systems that maybe aren't sending information our way. But again, it really, if we just really reach out and talk to the discharge planners or, set up a meeting with our network development team and discuss that with them, we've never really had to go down any pathway of, of concern, I guess. We do have pathways in place for people who, or for providers rather, who are not giving us timely documentation when there's a quality concern in place, but that has a little bit more oversight from the state. So we very closely align with the state on that.
Excellent. Next question. What are your suggestions for more actively engaging providers who are, for example, employed by a health system?
Never give up, never surrender. I think really is at first you don't succeed, try again. And it really helps to, we have a great CEO who engages and who is so well respected in our community that we tend to get a lot of pull when and if he gets involved. So we do appreciate that a great deal. So I would just work. No, I was realizing I probably didn't answer your question. Keep going, I think is how we would do it.
How has your position, your training as a doctor, what unique perspective do you bring to this particular issue of provider relationship management specifically?
Well, I guess, when I was practicing in academic medicine for about 20 years, I didn't know much about managed care. I didn't really know too much about insurance, and I honestly didn't care. I was doing my job, but and so from that perspective, there has to be when we engage with providers, we really have to come to a common place. We have to come to a mutual understanding of our goal, and we do have shared goals and shared values, and it's really around patients and patient care. So I think if you can really focus it's like in mediation. In mediation, if you can find a common agreement, something a statement that you both agree on, and then build from there, you generally have a greater, in fact, a really strong chance of coming to a resolution. And so, find your commonalities, know what's going to be important for your providers. Don't make it all about the MCO. If you can make it about what the MCO and the providers can do together, and that seems to be more effective.
Excellent. Now moving on to our last question for the day. So what are some things payers would like to know from providers about how providers want to interact with payers?
Well, I think as a payer, we'd like to know how we could interact together more efficiently. We, of course, do not wish to be a burden on providers. That doesn't help anybody. But we also know that we are required to gather documentation and clinical documentation based on their performance of different quality measures. So how can we best do that? What can we bring to the table to help you besides 200% of Medicare, which it's just not feasible when there are only limited resources. So how can we make something work, and how can we partner? I think that's what we'd like to know, or I think that's what we'd like to know.
Excellent. That concludes today's healthpayerintelligence.com presentation. Special thanks to our speaker, our audience, and our sponsor, Appian. Thank you and goodbye.